Assalamu alaikum. Today I'll discuss about the renal system. This is the chapter 26 of the textbook of physiology, that is Guyton and Hall. Urinary system, functional anatomy, and urine formation by the kidneys. So, what are the functions of kidney? There are multiple functions of the kidneys. Most of the people are familiar with one important function of the kidneys to read the body of waste materials that are ingested or produced by metabolism. The second function that is especially critical is to control the volume and electrolyte composition of the body fluids. For water and virtually all electrolytes in the body, the balance between intake and output is maintained largely by the kidneys. This regulatory function of the kidney maintains the stable internal environment necessary for the cells to perform their various activities. The kidneys perform their most critical functions by filtering the plasma and removing substances from the filtrate at variable rates, depending on the needs of the body. Ultimately, the kidneys clear unwanted substances from the filtrate, therefore from the blood, by excreting them in the urine while returning substances that are needed back to the blood. So, what are the functions of kidney? Excretion of metabolic waste products and foreign chemicals, regulation of water and electrolyte balance, regulation of body fluid osmolality and electrolyte concentration, regulation of arterial pressure, regulation of acid-base balance, regulation of erythrocyte production, secretion, metabolism, and excretion of hormones. Next, gluconeogenesis. So the first point, excretion of metabolic waste products, foreign chemicals, drugs, and hormone metabolites. The kidneys are primary means for eliminating most of the waste products of metabolism that are no longer needed by the body. These products include urea. Urea is formed from the metabolism of amino acid, creatinine from muscle creatine, uric acid from nucleic acid, end products of hemoglobin breakdown, bilirubin, metabolites of various hormones. These waste products must be eliminated from the body as rapidly as they are produced. The kidneys also eliminate most toxins and other foreign substances that are produced by the body or ingested, such as pesticide, drugs, and food additives. So you will have to know this part, that is excretion of metabolic waste product, chemicals, drugs, hormone metabolites. And you will have to remember, and you may ask in the Bible, that is from where urea is formed. It is from the metabolism of amino acid, from where creatine comes, from muscle creatine, uric acid, it comes from nucleic acid, an end product of hemoglobin breakdown, bilirubin. So this point you should remember. Next function of the kidneys are regulation of water and electrolyte balance. For maintenance of homeostasis, excretion of water and electrolytes must match intake precisely. If intake exceeds excretion, the amount will of the substance in the body will increase. If intake is less than excretion, the amount of substance in the body will decrease. Although temporary imbalances of water and electrolyte may occur in various physiological and pathological conditions associated with altered intake or renal excretion, the maintenance of life depends on restoration of water and electrolyte balance. So you may take large amount of water or you may take less amount of water. If you take large amount of water, it will be excreted out. If you take less water, it will be stored in your body. This is maintained by the kidney. Intake of water and many electrolytes is usually governed by a person's eating drinking habits, requiring the kidneys to adjust their excretion rate to match the intake of various substances. This is a figure. This figure shows the response of the kidneys to a sudden tenfold increase in sodium intake from low levels of 30 milliequivalent per day to a high level 300 milliequivalent per day. Within 2 to 3 days after reaching the level of 300 milliequivalent per day, sorry, within 2 to 3 days after raising the sodium intake, renal excretion also increases to about 300 milliequivalent per day, so that the balance between intake and output is rapidly re-established. However, during the 2 to 3 days of renal adaptation to the high sodium intake, there is a modest accumulation of sodium that raises extracellular fluid volume slightly and triggers hormonal changes and other compensatory response that signal the kidneys to increase their sodium excretion. Here is told that if you take more sodium, that is tenfold increase from 30 to 300 milliequivalent per day, within 2 to 3 days, this will be re-established. That is, at the first time, the sodium concentration in the blood will be increased, and this will trigger different hormonal um, changes and other compensatory responses that signal the kidney to increase their sodium excretion. And these hormones and other compensatory responses will stimulate kidney to increase the sodium excretion. The capacity of the kidneys to alter sodium excretion in response to changes in sodium intake is tremendous. Experimental studies have shown that in many people, sodium intake can be increased to 1500 milliequivalent per day, more than 10 times normal, or decreased to 10 equivalent per day, less than 0.1 of normal, with relatively small changes in the extracellular fluid volume or plasma sodium concentration. This phenomenon is also true for water and most other electrolytes such as chloride, potassium, calcium, hydrogen, magnesium, phosphate, iron. In the next few chapters, it will be discussed. Regulation of arterial pressure, that is, blood pressure maintenance, is a very important part of kidney function. The kidneys play a dominant role in long-term regulation of arterial pressure by excreting variable amounts of sodium and water. The kidneys also contribute to short-term arterial pressure regulation by secreting hormones and vasoactive factors or substances. Example, renin, and lead to the formation of vasoactive product, that is angiotensin 2. Regulation of acid-base balance. Kidney is a very important organ to maintain our acid base in our body. The kidneys contribute to acid-base regulation along with the lungs and body fluid buffers by excreting acids and by regulating the body fluid buffer stores. The kidneys are the only means of eliminating certain types of acids from the body, such as sulfuric acid and phosphoric acid, which are generated by the metabolism of proteins. Regulation of erythrocyte production. The kidney is a very important organ for erythropoiesis, that is, formation of RBC. The kidneys secrete erythropoietin is a very important hormone which stimulates production of red blood cells by hematopoietic stem cells in the bone marrow. One important stimulus for erythropoietin secretion by the kidneys is hypoxia. The kidneys normally, that is, hypoxia stimulate formation of erythropoietin. The kidneys normally account for almost all the erythropoietin secreted into the circulation. Most of the erythropoietin is secreted from the kidney. In people with severe kidney disease or who have had their kidneys removed and have been placed on hemodialysis, severe anemia develop as a result of decreased erythropoietin production. Regulation of 1,25-dihydroxyvitamin D3 production. Kidney is a very important organ for activation of vitamin D. The kidney produces 1,25-dihydroxycholecalciferol, the active form of vitamin D, by hydroxylating this vitamin at the number 1 position. Calcitriol is essential for normal calcium deposition in bone and calcium reabsorption by gastrointestinal tract. As this calcitriol plays an important role in calcium and phosphate regulation, that is, vitamin D increases blood calcium level. Glucose synthesis. The kidney has another function to maintain blood glucose level, while the kidney's capacity to add glucose to the blood during prolonged period of fasting rivals that of the liver. So you should know that kidney synthesize glucose from amino acid and other precursors during prolonged fasting, a process referred to as gluconeogenesis. So in fasting condition, kidney helps to maintain blood glucose level. With chronic kidney disease or acute failure of the kidneys, these homeostatic functions are disrupted and severe abnormalities of body fluid volumes and composition rapidly occur. With complete renal failure, enough potassium, acid, fluid, and other substances accumulate in the body to cause death within a few days unless clinical interventions such as hemodialysis are initiated to restore, at least partially, the body fluid and electrolyte balance. So we have discussed here about the functions of kidney and the functions of the kidney, the point that we have discussed elaborately here, and you will have to study it very mindfully that this question will come in written and you will be asked in Viva. Physiologic anatomy of the kidney. General organization of the kidneys and urinary tract. The two kidneys lie on the posterior wall of the abdomen, outside the peritoneal cavity. We know that there are two kidneys lying on the posterior wall of the abdomen, outside the peritoneal cavity. Each kidney of the adult human weighs about 150 gram and is about the size of a clenched fist. The medial side of his kidney contains an indented region called hilum, through which pass the renal artery and vein, lymphatics, nerve supply, and ureter, which carries the final urine for the kidney to the bladder. That is, ureter carries final urine, where it is stored until the bladder is empty. The kidney is surrounded by a tough fibrous capsule that protect its delicate inner structures. If the kidney is bisected from top to bottom, the two major regions that can be visualized are the outer cortex and the inner medulla regions. The medulla is divided into 8 to 10 cone-shaped masses of tissue called renal pyramid. So renal pyramid is 8 to 10. What is the uh, amount of renal pyramid? 8 to 10 cone-shaped mass. The base of each pyramid originates at the border between the cortex and medulla and terminates in the papilla, which projects into the space of the renal pelvis, a funnel-shaped continuation of the upper end of the ureter. That is, pelvis is funnel-shaped. The outer border of the pelvis is divided into open-ended pouches called major calyx that extend downward and divide into minor calyx, which collect urine from the tubules of each papilla. The walls of the calyces, pelvis, and ureter contain contractile elements that propel the urine toward the bladder, while urine is stored until it is emptied by micturition, discussed later in this chapter. This is the physiological anatomy of bisection of kidney. Renal blood supply. Blood flow to the two kidneys is normally about 22% of the cardiac output. That is 1100 ml per minute. You will have to know it and you will have to memorize it. Renal artery enters the kidney through the hilum and then branches progressively to form the interlobar arteries. That's mean renal artery enters through the hilum and branches into interlobar arteries, arcuate arteries, interlobular arteries. It is also called radial arteries and afferent arterioles, which lead to the glomerular capillaries, where large amounts of fluids and solutes, except the plasma protein, are filtered to begin urine formation. So this point you will have to understand and should remember that plasma protein, except the plasma protein. Plasma protein is not filtered in the glomerular filtrate. Why? Because plasma protein is negatively charged and the glomerular membrane is also negatively charged. The distal ends of the capillaries of each glomerulus coalesce to form efferent arteriole, which lead to second capillary network, the peritubular capillaries that surrounds the renal tubules. The renal circulation is unique in having two capillary beds, the glomerular and peritubular capillaries. So, renal circulation is a peculiar circulation in which there is two capillary beds, one glomerular capillary bed, another peritubular capillary bed, which are arranged in series and separated by the afferent arterioles. These arterioles help regulate the hydrostatic pressure in both sets of capillaries. High hydrostatic pressure in the glomerular capillaries, 60 mm mercury, cause rapid filtration, whereas a much lower hydrostatic pressure in the peritubular capillaries permit rapid fluid reabsorption. Glomerular capillary has hydrostatic pressure 60 mm mercury that causes filtration. On the other hand, low hydrostatic pressure in peritubular capillaries cause fluid reabsorption. By adjusting the resistance of the afferent and efferent arterioles, the kidneys can regulate the hydrostatic pressure in the glomerular and peritubular capillaries, thereby changing the rate of glomerular filtration, tubular reabsorption, or both in the response of the body's homeostatic demand. Peritubular capillaries, this is glomerular capillary, this is afferent arteriole, this is efferent arteriole. This efferent arteriole again form capillary that is called peritubular capillary. So renal circulation have two capillary bed, glomerular capillary and peritubular capillary. The peritubular capillary empty into the vessel of the venous system which run parallel to the arteriolar vessels. This parallel to the arteriolar vessel and drain into the venous system. The blood vessels of the venous system now form interlobular vein, arcuate vein, interlobar vein, and renal vein, which leaves the kidney beside the renal artery and ureter. What is the functional unit of the kidney? The nephron is the structural and functional unit of the kidney. So if you asked what is nephron? Nephron is the functional unit, structural and functional unit of the kidney. What is the amount of nephron in a normal human? Each human kidney contains about 8 lakh to 10 lakh nephrons. Each of these is capable of forming urine. The kidney cannot regenerate. Remember it. Kidney cannot regenerate nephrons. Therefore, with renal injury, disease, or normal aging, the number of nephrons gradually decreases. After age 40 years, the number of functioning nephrons usually decreases about 10% every year. Note it. After 40 years, 10% nephron decreases every 10 years. At age 80 years, many people having 40% fewer functioning nephrons. At 80 years, only 40% functioning nephrons will remain. Then they have died at age 40 years. This loss is not life-threatening because adaptive changes in the remaining nephrons allow them to excrete the proper amounts of water, electrolytes, and waste product. But according to age, it will decrease, but it will be not life-threatening because adaptive changes will occur. Each nephron contains a tuft of glomerular capillary called the glomerulus, through which large amounts of fluid are filtered from the blood, and a long tubule in which the filtered fluid is converted into urine on its way to the pelvis of the kidney. So this is nephron. This is a nephron where there is Bowman's capsule, where the plasma is filtered. Then it passes through long tubules, proximal tubule, descending loop of Henle, ascending limb, thick ascending limb, then distal tubule, collecting duct. Here it is said each nephron contains stuff of glomerular capillaries called glomerulus, which through which large amounts of fluid are filtered from the blood, and a long tubule which, in which filtered fluid is converted into urine on its way to the pelvis. The glomerulus contains a network of branching and anastomosing glomerular capillaries. This is glomerulus. This is Biomass capsule. What is glomerulus? Glomerulus contains a network of branching and anastomosing glomerular capillaries that, compared with other capillaries, have high hydrostatic pressure. The glomerular capillaries are covered by epithelial cells, and the total glomerulus is encased in Bowman's capsule. This glomerulus is capsuled by Bowman's capsule. Fluid filtered from the glomerular capillaries flows into the Bowman's capsule and then into the proximal tubule, which lies in the cortex of the kidney. From the proximal tubule, fluid flows to the loop of Henle, which is deep into the renal medulla. Remember it. Loop of Henle, where present, deeps into the renal medulla. Proximal tubule lies in the cortex of the kidney. This cortex is medulla. Proximal tubule lies in the cortex, loop of Henle in the medulla. Very important point. Remember it. Each loop consists of a descending and an ascending limb. That's in the loop of Henle. Consists of descending and ascending limb. The walls of the descending limb and lower end of the ascending limb are very thin and therefore are called thin segment of the loop of Henle. Again, the walls of the descending limb, and and the walls of the ascending the walls of the descending limb and lower end of the ascending limb are very thin and therefore are called thin segment of the loop of Henle. After the ascending limb of loop returns part way back to the cortex, it will become much thicker. Here, this is hill. From here, the ascending limb becomes thick and enters into the cortex. After the ascending limb of the loop returns partway back to the cortex, it will become much thicker. This segment is referred to as thick segment of the ascending limb. At the end of the thick ascending limb is a short segment that has in its wall a plaque of specialized epithelial cells known as macula densa. Macula densa. At the end of the thick ascending limb, this is at the end where a, a zone that is macula densa is present. That is a connection between the macula densa. Macula densa. As discussed later, the macula densa plays an important role in controlling nephron function. Beyond the macula densa, fluid enters the distal tubule which, like the proximal tubule, lies in the renal cortex. The distal tubule is followed by the connecting tubule, cortical collecting tubule, which lead to cortical collecting duct. The initial parts of 8 to 10 cortical collecting ducts join to form a single larger collecting duct that runs downward into the medulla and becomes the medullary collecting duct. The collecting duct merges to form progressively larger ducts that eventually empty into the pelvis tips of the renal papillae. This is thick ascending limb of loop of Henle. At the end, there is macular densa present, then distal tubule, then connecting tubule, then cortical collecting tubule, medullary collecting tubule, collecting duct. 8 to 10 cortical collecting duct join to form single larger collecting duct that runs downward into the medulla and becomes the medullary collecting duct. The collecting ducts merge to form progressively larger ducts that eventually empty into the renal pelvis through the tips of the renal papillae. Each kidney, there are about 250 of these very large collecting ducts, each of which collects urine from about 4,000 nephrons. Regional difference in nephron structure, cortical and justamedullary nephrons. Regional difference of nephron structures, cortical, justamedullary, cortical, medullary. Although each nephron has all the components described earlier, there are some differences depending on how deep the nephron lies within the kidney mass. The nephrons that have glomeruli located in the outer cortex are called cortical nephrons. They have short loops. Remember, cortical nephrons have short loops of Henle that penetrate only a short distance into the medulla. This is cortical nephron, short loop of Henle. Medullary nephron have long loop of Henle. About 20 to 30% of the nephrons have glomeruli that lie deep in the renal cortex near the medulla and are called justamedullary nephron. How many? 20 to 30% justamedullary nephrons. These nephrons have long loops of Henle that deeply into the medulla, in some cases all the way to the tips of the renal papilla. The vascular structures supplying the justamedullary nephrons also differ from those supplying to the cortical nephrons. For the cortical nephrons, the entire tubular system is surrounded by an extensive network of peritubular capillaries. Cortical nephrons, the entire tubular system is surrounded by an extensive network of peritubular capillaries. This is peritubular capillaries. For the justamedullary nephrons, long efferent arterioles extend from the glomeruli down into the outer medulla and then divide into specialized peritubular capillaries called vasa recta. This is efferent arteriole divided to vasa recta. But in cortical nephron, what happens? This is the vascular structure supplying. This is this is. The vascular structures supplying the juxtamedullary nephrons differ from those supplying the cortical nephrons. What is the difference? For cortical nephrons, the entire tubular system is surrounded by an extensive network of peritubular capillaries. But in juxtamedullary nephrons, long efferent arterioles extend from the glomeruli down into the outer medulla and then divide into specialized peritubular capillaries called vasa recta. That is, vasa recta present in juxtamedullary nephrons, and in the cortical nephron there is also peritubular capillaries, but these capillaries are different from the juxtamedullary nephron. Vasa recta. So what is vasa recta? Vasa recta. Long efferent arteriole extend from the glomeruli down into the outer medulla and then divide into specialized peritubular capillaries that are called vasa recta, which extend down into the medulla, lying side by side with the loops of Henle. Like the loops of Henle, the vasa recta return toward the cortex and empty into the cortical veins. This specialized network of capillaries in the medulla plays an important essential role in the formation of concentrated urine. This will be discussed following in the following discussion. So today uh, we have discussed about the physiological anatomy of the nephron, functions of the kidney, and circulation of the nephron. So up to this, you read it, and I think you will understand the function of the kidney and structure of the nephron. Thank you. Thank you to you all. Please subscribe me so that I may uh, made another videos to help you.